Good afternoon, and thank you very much for the opportunity to present today. My name is Bogacki. I'm a surgical resident from Krakow, Poland, and I'm going to speak a little bit about the impact of full spectrum endoscopy on detection of lesions in different regions of the colon. As you all know, colonoscopy with polypectomy is a widely adopted way of reducing colorectal cancer mortality, and it's proven that there's a strong correlation between the adenoma detection rate, which is one of the indicators of the quality of colonoscopy screening, and the reduction of risk of colorectal cancer. However, it still remains a challenge because it's estimated that around 25% of all the adenomas are being missed on a standard colonoscopy screening exam. So what we're trying to do is to increase the adenoma detection rate. There are many factors that affect the ADR, and one of the factors is technical improvements, and fused endoscopy, which is full spectrum endoscopy, is one of those improvements, and that's what I'll focus on. So fused endoscopy is an improvement of standard frontal viewing endoscopes with the addition of two cameras on both sides of tip of the endoscope. So there's a left camera and the right camera, in addition to the standard forward viewing camera, and this allows us a 330-degree widescreen panoramic view of the mucosa of the colon. So we did a randomized prospective study at our center. We included all the patients for colorectal cancer screening, polyp surveillance, and diagnostic evaluation, and we excluded patients who had prior abdominal surgery and inflammatory bowel disease. And then we randomized them into two groups. One group received a standard forward viewing colonoscopy with Olympus 190 platform, and one group underwent colonoscopy with fused endoscopy. All of the patients received the same bowel preparation, and all the exams were performed by experienced endoscopists that had at least 5,000 exams done with standard forward viewing colonoscopy, and at least 10 fused exams to at least try to beat the learning curve of this device. So this is a flowchart of the inclusion of the patients. We invited 734 patients to our study, had to exclude 309, mostly because they had prior abdominal surgery. 64 refused to take part in the study. They did not sign the written consent, and 27 were in treatment for inflammatory bowel disease, so they were excluded as well. 17 patients did not complete the colonoscopy, mostly due to poor bowel preparation. 5 patients had strictures due to tumor, and 2 asked us to stop the examination because of pain and discomfort. So we were left with 408 patients. 209 were randomized to a standard forward viewing colonoscopy, and 199 to a fused colonoscopy. There were no differences in terms of group characteristics between the group. The distribution of gender was similar. Bowel preparations were pretty high, with scores above 8, and the mean BMI in both groups were around 27. There was no statistical significance in this regard. The first difference that we notice is the Cecum intubation time. When you look at the Cecum intubation time, the mean time in standard frontal viewing colonoscopy, it was 235 seconds, and in fused colonoscopy, it was 311 seconds. So it took longer to intubate the Cecum with this device, and it was statistically significant. We didn't see any difference in terms of withdrawal time between the devices. And why is that? Maybe it's because at first when you use this device it seems a little bit confusing because you have to follow three live images simultaneously, so it's almost like watching a 3D movie. At first it gives you a little bit of a headache, but then you kind of start to like it. So when we looked at our results at the whole colon, we did not see any difference in terms of adenoma detection rate, advanced adenoma detection rate, and diverticulite detection rate between the groups. The adenoma detection rate was a little bit higher in the fused group, 2% higher, but the statistical significance was not not reached. So then we broke it down into 3 different regions of the colon: the right, which is the ascending, the transverse, and the descending colon. We looked at sheer numbers of adenomas detected, advanced adenomas, and the verticali detection rate in all of these regions, and we did not find any statistically significant differences in these aspects. However, when we looked at the total number of polyps detected, we did see that we detected much more polyps in the right colon using fused endoscopy and in the transverse colon, and that was statistically significant. However, there was no difference in the polyp detection rate in the left colon. So to conclude, we think that fused endoscopy is a safe and feasible method of colonoscopy screening. We did find that cecum intubation time was significantly longer using this device, and we found more polyps in the right and transverse colon using a fused device than standard frontal viewing colonoscopy. We did not see any difference in terms of polyp detection in the left colon, and we didn't see any difference in terms of adenoma detection rate, advanced adenoma detection rate, and diverticuli detection rate. The limitation of the study is that it was a relatively small cohort, so as you could see, the adenoma detection rate was a little bit bigger in the fuse group, but maybe due to the small cohort, we did not achieve the statistical significance. A second limitation, it was very experienced endoscopists, and there are many publications that say that there is bigger benefit of fused endoscopy in endoscopists that are not experienced, that could benefit more from this device. So because very experienced endoscopists, they tend to not miss as many adenomas, so that might be a limitation. And the learning curve that is in some publications that is estimated to be as long as months. And as I said, only 10 exams had been made by the endoscopists before this study, so it might be that the learning curve is still not overcome in that study. Thank you.
Thank you.